Good morning, Marshall. I think we can start because I can see that we are a quorum.
Good morning, Chairperson. Would you like me to flag the presentation?
Not the presentation, the agenda.
Sorry, the agenda. Yes, Chairperson. Apologies. Good morning, Chairperson again, and good morning, members. Good morning, everyone on the platform. I'll do so.
Good morning to the honorable members, to the delegation from the SANAC, as well as our support staff. Honorable Subande, can you please mute? First and foremost, I want to welcome the honorable members to the first Select Committee on Social Services in the third term, as well as our support staff, and then a warm welcome to the delegation from SANAC under the leadership of the doctor, the CEO of SANAC. So welcome to this meeting. So the meeting is officially open. Honorable members, the agenda is in front of us. Can I get a mover for the adoption of the agenda? Honorable Adriaanse and Honorable Masumpa.
Good morning, Honorable Chairperson and everyone on the platform. I move to adopt the agenda. Thank you, as is.
Thank you very much, Honorable Adriaanse. Honorable Masumpa.
Good morning, Chairperson. I move to second the adoption of the agenda. Thank you.
Thank you very much, Honorable Masumpa. And thank you very much to Honorable Makwele as well. So this agenda is duly adopted. We will move now over to another point on the agenda, and that is that of the apologies. Marshall, any apologies?
Chairperson, we don't have any apologies. All members are in. Thank you.
Thank you very much, Marshall. So now we will move over to the next item on the agenda. It's the briefing by the South African National AIDS Council, SANAC, in terms of the trends of HIV and STIs in the country, particularly amongst 13 to 50-year-olds, and key drivers of dual infection of HIV and STIs, including teenage pregnancy, as well as employed tactics to prevent dual infection of HIV and STIs, including teenage pregnancy, and then the status of the effectiveness of provincial councils on AIDS, district councils, as well as local councils on AIDS. So we will give now over to the doctor, the CEO, to take us through. And I will request the presenters to just switch on their videos when they introduce themselves so the members can see who they are dealing with. Thank you very much. Over to you, Doctor.
Good morning, Chair, and good morning to the honorable members. Thank you very much for having SANAC today. Once again, Chair, I will also reiterate that it is our first time being given this chance, and we really appreciate the opportunity, and we do not take it lightly. I'd like to start by introducing the members of my team, so if they can turn their cameras on as I mention their names. I'll start with Mr. Nelson Dlamini.
Good morning, Chair. Good morning, honorable members. I hope I am visible. My camera has issues. Okay, there it is.
Can't
And
see you yet. Yes.
Okay. Yes, my name is Nelson Dlamini. Okay, I think there's a lag. I'm not sure if it's my network, but it's Nelson Dlamini from the SANAC Secretariat, heading communications. Thank you.
Thank you very much, Dlamini. I'm then going to ask Dr. Roger Pili.
Good morning, Chair. Good morning, CEO. My name is Roger Pili from SANAC. Apologies,
Roger, put your camera on. Your camera on?
I don't have the camera as here, Chair. My camera is not working, so apologies for that.
Okay, apologies about that, Chair. I think that says we need to improve on the tools of trade. I do apologize. May I then ask Ms. Ntabiseng Mogowe? Ntabiseng?
Good morning. I hope my camera is visible. Good morning. My name is Ntabiseng Mogowe. I'm the Adolescents and Young People Technical Lead from SANAC. Thank you.
Thank you so much, Ntabi. May I please then ask Mr. Leboa Malaka?
Morning, Chair, and morning members of the committee, and my boss, CEO. I'm Leboa Malaka. I'm the technical advisor for the AIDS Councils with the South African National AIDS Councils. We look forward for this meeting. Thank you.
Thank you so much, Malaka. And Chair, my name is Dr. Thembisile Kulu. I am the Chief Executive Officer of the South African National AIDS Council, and I also serve as the chairperson of the Global Fund Country Coordinating Mechanism in the country. So, Chair, may I ask Malaka Roger, are we able to project the slides? Can we proceed with the presentation, Chair?
Yes, you may.
With your permission. Okay, thank you so much. Malaka Roger, I don't know who's presenting from your side. Please project the latest version.
Okay, sure. I will try to project from my side. I'm trying to share.
Thank you.
It says
Chair,
host disabled participant screen sharing here.
So you've just been allowed. I see on the screen now. Roger is now the co-host. Please try again. Thanks, Roger. So whilst Roger is trying to show the slides, honorable members, today we are going to speak to South Africa's HIV, TB, STI trends. And we just brought in a bit of TB because there's also a high rate of HIV, TB co-infection. We didn't focus on it because it wasn't requested, but we thought that a lot of people living with HIV are still dying of TB. So we will give you an idea of what that looks like as well. We'll also look at childhood and teenage pregnancy because we're having a lot of 9, 10, 11-year-olds falling pregnant on top of the teenagers as well as the adolescent girls and young women. And then we'll state some of our prevention efforts. And critically, we will then speak to the members about the functionality of the AIDS councils. And these are the structures or the governance structures that are meant to carry the response in every community in this country. So Roger, if we can please then go to slide number 1. So Chairperson, South Africa has made I'm getting some feedback, Chair. I'm not sure if somebody's mic is on, but we've made significant progress in terms of the HIV response. I think
Sorry,
many of
CEO.
our honorable...
Yes, can Roger Pili please mute, but I see you have muted, so you can proceed.
Also put on slide mode. Okay, also put on slide mode. Thank you, Chair. Thank you, Chair. So, Chair, as mentioned, we've made significant responses in terms of the gains that we saw in the HIV response, despite where we started and where we are now. We are still the country with the highest burden. Roger, please go back to that first slide, the opening remarks. Please don't change yet. No, backwards. Thank you. Once more back. Yes. But the program still remains quite uneven in terms of the 3 priorities that you've asked us to speak to the honorable members about. And we know that HIV, TB, STIs, as well as childhood and teenage pregnancy have got both structural, relationship, behavioral barriers, and therefore we can't medicalize ourselves out of that solution. They are an interconnected challenge, and therefore our response has to be multi-sectoral, which means we also address the other drivers like structural, like I mentioned. And thirdly, the method or the mode of delivery, it becomes very important because none of any of our interventions reaches the communities that we are trying to serve without adequately resourced AIDS councils. And by that, I mean financial, human, and other resources at national, provincial, and local level. So part of today's focus will be exactly that, where our burden sits, where our prevention needs to be joined up, and how SANAC can then be strengthened to deliver results. Next slide, please, Roger. Next slide. So the role of SANAC, very, very briefly, this is this one in the next slide. For members who might be less familiar with the mandate, we are going to take you through that, speak briefly through some of our challenges, speak to the populations and the locations where we have a lot of burden in terms of HIV, STIs, AIDS, TB, as well as HIV, look at our interventions in terms of prevention, but also the functionality of the provincial and district AIDS councils. We will then, Chair, I assure you that the mandate of SANAC is to develop what we call the National Strategic Plan for HIV, TB, and STIs. And this is the plan that brings together the entire country to pull in one direction as we address the issues of HIV, TB, and STIs. And the way that we are able to do that as the SANAC Secretariat nationally is by pulling across all the spheres of government. So you'll hear when Malaka presents, he'll speak to the provincial AIDS councils, the district AIDS councils, the local AIDS councils, and we'll make a lot of reference to civil society and the private sector, because these are the three legs on which the SANAC Council stands, and you'll see that better in the next slide. And we have subnational structures, which we like to refer to, not yet, Roger, as the law of diminishing returns, where the lower you go to ward level, which is where the problem actually is, we don't get as much resourcing and participation. And functionality of that at that level actually requires sustained monitoring. It requires political buy-in and stable administrative capacity, as well as a reliable funding. Next slide, Roger. So this next slide. So this slide, Chair, simply refers to the governance structure of SANAC. So the highest decision-making body of SANAC is called the plenary. The plenary is chaired by the Deputy President, together with a co-chairperson of civil society, plus a co-chairperson from the private sector. So those would be the three at the bottom. And then on the extreme right-hand side, you will see a program review committee, and under that would be the technical task teams. So the program review committee is essentially what we refer to as a technical clearinghouse. And this is where we approve new policies. This is where we've got our eye on what's happening in the world. And the latest example, for instance, is the results that came out on lenacapavir towards the end of last year, and how South Africa in June launched lenacapavir as a new innovation. That was a decision that was taken via the intervention of the Program Review Committee. What feeds into the decisions of the Programmatic Review Committee is the Programmatic Technical Task Teams. And these task teams actually focus on various elements of the response, from prevention to treatment to human rights, to making sure that even the estimates and the numbers and the data that's driving the policy decisions are correct. If Chair and members look on my left, the left-hand side of the slide, you will see that there's the Resource Mobilization Committee, and that is essentially us making sure that the National Strategic Plan is fully resourced, but it's also important that our role as coordinators is also resourced. And a key role of the Resource Mobilization Committee is also making sure that donors are coordinated. We've had multiple donors in the country, the likes of PEPFAR, Global Fund, GIZ, etc. And we have had some challenges where donors come with their own priorities, wanting to use own systems. And we've started very much moving towards making sure that countries set national priorities, that donors use national systems in order to make sure that if they need to pull out, we remain sustainable. I then sit chair as the CEO of the SANAC Trust, which is on the complete left-hand side. And the SANAC Trust has got a board of 11 members. All of them are appointed by the Deputy President in consultation with the Minister of Health, as well as the Chair of Civil Society, and they are multi-sectoral in nature. And 5 of them are appointed by the Deputy President as independent members, so not necessarily coming from SANAC, and the rest would come from SANAC structures. We are then the Secretariat, and that model, Chair, that you see, which I've just described, from the trust to the program review to the money side in the middle, is replicated at every province, at every district, at every locality, and at every ward. So PCA would be the Provincial Council on AIDS, DAC would be the District AIDS Council, LAC, Local AIDS Councils, and Ward AIDS Councils, and they would then have the requisite administrative support, which is the Provincial Council on AIDS, our equivalent. So most of them sit in the offices of the Premier, and the reason we have it that way is so that they've got convening power to call other departments to make sure that they are aligned. Next slide. So the SANAC mandate, Chair, I will not read every word because I, as much as we may have sent these late, which I do apologize for, I was in Brazil. There was a lot of drama coming back from the conference and we arrived quite late. So we did revise these a few, but I'll be brief. Our mandate as SANAC is broadly that when in 2000, HIV became clear that it was a multi-sectoral issue, not just a health issue. The department then created SANAC to make sure that we advise government on HIV-related policy, we promote consensus, we bring civil society to the fore, and we also mobilize resources from the private sector, and we ensure that the people are able to hold government accountable, but at the same time that government is also able to hold the people accountable, because you will see in many of the donor projects, donors were funding civil society organizations to render services in areas that government can't reach. So where civil society organizations were essentially functioning as a safety net because there isn't a clinic at every corner. And that is where civil society organizations were then acting. And honorable members, every one of these functions really depends on SANAC having the authority to convene resources, to coordinate, and to make sure that we are able to deliver effectively. And that is precisely where our problems lie, especially at the lower level, but generally on a funding level. So when there are new proposals, we would present that, and then there would be a policy change, like I mentioned with Lena Kepave. Next slide, Roger. So members, you will note in the next slide, UNAIDS has what we call the 3 1s. I do apologize. This slide is very, very wordy, but if the members can maybe listen to me and just focus on the areas that are in bold or in dark black. So UNAIDS mentions the 3 1s principles, and they essentially say there should be one coordinating authority, one national strategic plan, which is one framework, and one M&E system, really driving the entire country. So whether it's the private sector or the donors or civil society, that is essentially the one guiding document that they should follow. And it's to make sure that we are able to then hold them accountable against what is in the National Strategic Plan, because the strategic plan contains our targets as SANAC for the country. It also contains the National Development Plan targets, but it also contains the targets of our international goals, the Sustainable Development Goals. The challenge that we've had, honorable members, is that we have generally been underfunded as SANAC. I joined in October 2020, and at that time we were around 10 million short. Right now, we are at a point where our annual budget is about 84 million, and this is for us to be able to support the functioning of SANAC, not just at national level, but also at provincial level, and sometimes to support civil society with the work that they do. We get funding of about 32 million from the Department of Health, and 18 million from the Department of Social Development. So that is about 50 million. So we are only funded at 60% of the requirement. So the existing funding arrangements are truly insufficient for us to be able to carry out our coordination function based on that shortfall. So what we've then done, Chair, is that we have tapped into donors, like the Global Fund, like GIZ, even a World Bank Pandemic Fund, etc. And the kind of implementation that we would then do, for instance, is to write the midterm review of the National Strategic Plan in order to inform the writing of the Global Fund grant, but also to inform the writing of the National Strategic Plan. But what that then does, when we start competing for funding with our stakeholders, it creates a perception that we are a referee and a player. Because here we are supposed to be doing donor coordination, but because we are underfunded, we are supposed to be actually monitoring and guiding these donors. And without saying too much, Chair, sometimes it does become hard to bite the hand that feeds. So over 3 years ago, there was a plenary agreement that all SANAC departments should contribute to the operations of SANAC, starting with the offices of the premiers, but also taking it right up to our level. It wasn't so much an amount, but National Treasury was allowed to say, let your provincial treasury work with the offices of the premier and determine, based on the structure of SANAC and what is needed, what percentage can you contribute towards the running of SANAC. And I'm sad, Chair, to say that hasn't moved for a number of reasons, and we are still in the state where we are. So the funding shortfalls are hindering our ability to deliver and to actually, even now, we are preparing to write the next Global Fund grant, which we plan to write in January, because the current one is in the middle of the second year. And we were presenting yesterday, we are still short of 5 or 6 writers. And it really makes it quite difficult because we are a very consensus-driven country. We do need consensus when we submit a country grant to a funder. Next slide. So let me turn then, Chair, to the numbers, Chairperson. So South Africa itself actually accounts for about 20.5% of people living with HIV worldwide. So this is our global contribution, 20.5%. But in the country itself, 8 million people are living with HIV. And Chair will know that we are being measured by UNAIDS in terms of what we call the 95-95-95. That says 95% of people should know their status. Of those who know their status, 95% should be on treatment. And of that 95%, 95% should be virally suppressed. Our current number is 96, 83, 93. Now, we've only mentioned the second number of 83 to show that there is a treatment gap. That number of 83% is supposed to be at 95%, and that is why the minister launched the 1.1 campaign to make sure that we try to bring over 1 million back of people, over 1.1 million back onto treatment in order for us to meet our global goals, but also our own goals as a country for the health and well-being of our citizens. In terms of sub-Saharan countries, our contribution is 31.2%. And unfortunately, Chair, as much as our target, according to UNAIDS, is to be seeing less than 100,000 new infections by now, the latest Tembisa model, which is a model that's developed by Wits, Harvard, etc., to model HIV, we are still seeing 160,000 new infection. Progress has been substantial, but we are seeing a very high burden of TB HIV co-infection, as I said, about 54% to be actual. And just this year early, when we had TB Day, part of the placards that were carried were that in the last year, we lost about 56,000 people due to TB. So as much as there has been a reduced incidence, being new cases in TB, Since 2015, it's come down by 65%, and mortality has come down by 17%. It's still not as great as we'd like to see. And then accompanying then these epidemics of HIV and TB is the issue of STIs, childhood and teenage pregnancy. And we are actually starting to see what we refer to as the triple burden, especially amongst adolescent girls and young women. And this is new HIV infections, it's a pregnancy, teenage pregnancy, and it's gender-based violence. So it's the triple threat that we are seeing in this young group. And social and structural factors such as unemployment, limited access to education, and gender inequality actually render them more vulnerable. And what we sometimes label as reckless behavior sometimes is just a situation where they are desperate for economic survival, and sometimes they are being sent out to work in order to keep the families alive. Therefore, our NSP adopts a people-centered, human rights-based, multi-sector approach that doesn't address just the medical issues, but also looks at the social and structural drivers of these epidemics. Next slide. So the HIV burden by age and sex, Chair, as mentioned, the decline, we have seen much fewer infections have been occurring over time, I think since 2004, which is when we started the rollout. But it's not as big as we would like to see. But the effect has been because of, one, the huge rollout of antiretroviral treatment, because we know that once you put someone on treatment and they stay on treatment and they become undetectable, then they do not transmit. That's why we have what we call U equals U, undetectable equals untransmittable. It's also been a success of the prevention interventions, and I'll show you how many people we've started putting on oral prevention, and now we've just started with the injectable prevention. And also some of the behavior change programs, even though they are not as great as the one that I think, personally, one of the greatest ones that the country had was the one called Komanani. That was one of our best social behavior change programs. We haven't reached anything of that level yet, but I think because we have closeness to the people through civil society, we are using either local gatherings or community radio stations to keep the message going. So we do need to accelerate our progress to make sure we continue to invest in treatment, prevention, and care, and make sure that our people stay in care and are virally suppressed. And this is even more important, Chair, with the donors having pulled out. We were quite fortunate when PEPFAR pulled out in that our national fiscus covered about 77 to 80% of the HIV response, and therefore none of our patients did not get access to treatment. But the truth of the matter is that those who were getting access to treatment at community level were mainly key and priority populations, and they don't want to come to health facilities. So it was about us now trying to integrate to make sure that HIV services are not self-standing, to reduce the stigma, but to make sure as well that when they come, they get an integrated package delivered via a mobile coming to your community, and then you can check your diabetes, your hypertension, have your pap smear, etc. On the next 2 points, Chair, we wanted to show you just the difference in HIV prevalence amongst people aged 15 to 24. You'll note that as much as it was 5.2%, the difference between the females and the males is alarming. It's 6.9 prevalence in females and 3.5% amongst males. So in the age of 15 to 24, females are 2 times more likely to be infected than their male counterparts. Amongst people aged 25 to 49, the prevalence is 22.1%. And here we see that females are at 28% and males are only at 14.7%. Female prevalence does peak around the age of 35 to 39, and that's at about 34%. And then for males, it peaks around the age of 45 to 49. So for males, the highest number that we see is at that age, and they are sitting at about 27% of infection. We did launch a program, Chair, called the Global Coalition to End AIDS in Children, because we noted that children were being left behind. As much as we are also supposed to have reached 95, 95, 95 for children, that second 95, which I mentioned earlier, is 83% for adults, is only 63% for children when you drill down. And for us, this is just an indictment, because those adults that are getting treatment are the mothers and the fathers of these very same children. So we needed to find a way to bring communities in, address girls even before they fall pregnant, address young mothers, pregnant mothers, breastfeeding women, on how to make sure that they get access to prevention treatment services, not just during pregnancy, but also during labor and delivery, to make sure we reduce vertical transmission. And then you will see that provinces like KwaZulu-Natal, Mpumalanga, Free State, and Eastern Cape are still very high in terms of the number of people living with HIV. And in terms of new infections, which is the Eastern Cape incidence, it's the Eastern Cape, Free State, and Mpumalanga. Next slide, please. So, Chair, we normally look at male urethritis syndrome, which is a proxy or an indicator of sexually transmitted infections. They essentially signal ongoing sexual transmission. And you'll see, Chair, just the red dotted line is the average for the country. And at the very top, if we go to the extreme right, Eastern Cape is still number 1. Number 2 would be KZN, and number 3 would be Free State. I won't focus so much on the rest, but we've seen that the national incidence of male urethritis syndrome has actually risen from 18%. I apologize, Chair. At the top there, it does say percentage incidence over total male population. So that 18 is supposed to be 18%. So 18% in 2026 to a peak of 23% in 2023. But then it declined to 20% in 2025. And then in the Eastern Cape and KwaZulu-Natal, we have consistently recorded very high new rates of STIs, and they peaked in 2022 before they started declining. And most provinces showed a drop in 2020, followed by a rebound in 2021. And we normally tend to see this rebound, Chair, to be honest, very early in January, February, which is when people have been home for the months of from mid-November to December. We don't think there's condom use, because we also find that when we look at the data in January, February, it's not only high STIs, but also lots of loss to follow up and people having fallen off treatment. So while the incidence is declining, the levels do remain quite concerning in some of these provinces that I've mentioned. The number 1 sexually transmitted infection we see is gonococcus, gonorrhea. And syndromic management is what we do when we try to cover everything that could cause an STI, but it doesn't catch everything, which is why we are now moving towards point of care testing and trying to test for every STI so that we don't miss, for instance, syphilis or whatever else an individual might have. So the key takeaway here is that even though we peaked in 2022, male urethritis has declined, but Eastern Cape and KwaZulu-Natal do remain the provinces with the highest burden. Next slide, please. In terms of childhood and teenage pregnancy, Chair, once again, Chair, you'll note the country's average is the red dotted line. And at the top there, we do have Eastern Cape, Northern Cape, Mpumalanga, and KwaZulu-Natal, as well as Limpopo, being above the national average. This is one of the most difficult numbers that I will share today. just between 2024 and 2025, 117,000 girls aged 10 to 19 gave birth. And Eastern Cape, Northern Cape, KwaZulu-Natal, Mpumalanga, and Northwest remain above the national average, as I've mentioned. And Free State, Western Cape, and Gauteng remain with a lower than national average in terms of delivery between the ages of 10 to 19. And we know that pregnancy amongst young and adolescent girls remains and requires, a statutory response. So, Chair, we've been in multiple discussions with the Department, for instance, of Basic Education around some of the interventions that they're doing. And I'll be very brief. One of the key things that we see is when, I think during Christmas or New Year, when new babies are born, we get to see excitement and numbers being shared, but nobody ever tells us how old those mothers are. So we are moving towards mandatory reporting, especially for the under 16s, because this is statutory rape. Early identifications, so schools are now required to refer affected children for immediate care and psychosocial support. The comprehensive sexuality education, which took a while to take off because of some of the challenges we experienced, is also expected to help educate and identify children at risk quite early. I was listening, Chair, during the conference in Brazil, to one of the girls who went to a school where her governing body did not allow under the life orientation model for sexuality education. And she was sitting in Brazil and she was saying, I'm here, all I was taught was how to use roll-on. And the first thing that happened was that when I got to my higher institution, I got a sexually transmitted infection. And then the importance of community involvement. So the Department of Basic Education is really promoting partnerships with parents, with caregivers, with communities, with faith-based organizations, just to make sure that we improve supervision, raise awareness of child sexual abuse, and to strengthen their efforts. Next slide. So, Chair, the reason why these are interconnected, and I return to the point which I made earlier, it's to say that they are really not three separate epidemics. They are overlapping vulnerabilities in terms of the sexual and reproductive health requirements. Adolescent girls and young women remain disproportionately vulnerable, and untreated STIs actually increase their vulnerability not just to HIV and unintended pregnancy, but also to cancer of the cervix, because we know that at that point, the cervix is not developed enough. And the part of the cervix that has not been tucked in yet is the part where cancer starts. So the earlier the sexual debut, the higher the chances of developing cancer of the cervix. Hence, the importance of the cancer elimination strategy, which the department will be launching soon. So STIs are an important health burden in their own right, but we are looking for a multi-sectoral approach. And I've mentioned the issue of vulnerability, but for 13 to 50-year-olds, really, we still see that we require a range of responses, which I'll show on the next slide, rather than one prevention approach. Because when you look at our HIV budget as a whole, we then have a prevention budget, and of the prevention budget, only a percentage of that is for pre-exposure prophylaxis, and that is targeting people that are not living with HIV and trying to prevent them from getting HIV. So these challenges are not three separate epidemics. They are overlapping and have intersecting vulnerabilities, and they require us to have an integrated approach, including sexual reproductive health responses. Next slide. So who is mostly affected, Chair? I think that the first block, which is missing, Chair, I do apologize. My throat is acting up. I think I caught something on the plane. The younger ones, the 10 to 12-year age group I spoke about, and some of the strategies that are being implemented together with social development as the custodian for children, as well as the Department of Basic Education, together with communities. For 13 to 19-year-olds, I won't go into too much details, but we are seeing lots of early sexual exposure, teenage pregnancy, GBV, and it comes also from limited bodily autonomy and the ability or the lack of ability to negotiate condom utilization. For the ages 20 to 24, we see that they also remain still very vulnerable, and we continue with prevention coverage as an important one. But because these pills are taken daily, we do see a lot of pill burden. We see a lot of treatment fatigue, and we see them coming off and not staying on the PrEP. And therefore, the move towards a 1 monthly pill or a 6-month or a 12-month injection, I think would be more welcome, but it would then have to be surrounded with the message that this only protects you from HIV, but not from STIs or teenage pregnancy. For 20 to 25-year-olds, the burden still remains significant for males and females, as I showed earlier, Chair. So we are sustaining our testing and treatment. We are improving condom access, STI management. But we are continually seeing, Chair, that condom distribution does not necessarily translate to utilization. And that is something that our health communicators are working on. But the problem is that it's also reliant on self-reporting. But when you look at some of the declines around the STIs, it means that there is a possibility that people are using them. And the populations that we still think require intensified attention are the key populations. I mentioned, Chair, that key populations are not necessarily comfortable. Our sex workers, men who have sex with men, LGBTQI populations, feel that they're being discriminated at health facilities. So there is a lot of sensitization training that the department is leading to make sure that they are able to access. Young people and people with disabilities are also having the same problem. There's a perception that people with disabilities might not be engaging sexually, and that is far from the truth. And we are focusing on interventions that they require, driven by themselves and them telling us what would work best for them. People in informal settlements, youth that are not in education, not in training and out of schools are also very much vulnerable and not protected, and we are focusing on them. So we are really prioritizing high burden areas, and we are also driven by the age, the sex, the population, and the geography. We understand that not everyone is affected in the same way, and we know that inequalities, like poverty certainly drives TB. When people are living in a small house that is not ventilated, and there are many, when one has TB, there is a very high chance of transmitting it to others. Or when one has HIV, which is not well managed and not well controlled, it then results in opportunistic infections like TB. And in a household, children would then be most vulnerable, which speaks to the rollout of the TB prevention therapy. And then targeting those who most drive the epidemic. I spoke about our key populations and making sure that all our interventions are precision targeted, which means they have to be data driven for us to get better results. Next slide. So in terms of why the STIs and teenage pregnancies continue to intersect, I think I've also touched on this. I won't dwell, but the structural issues, be they poverty, unemployment, the relationship issues, the age disparate relationships, the blesser-blessee phenomenon, which really comes from economic dependency, is still a thing that is happening. The behavioral issues, the inconsistency in terms of condom utilization, but also the multiple sexual partners, which has essentially been normalized in certain societies. I was reading the paper, Chair, just before leaving for Brazil, and I actually saw that after that movie called The Polygamist, there was actually a period where condom utilization or condom buying did increase in our local garages. So it was a good phenomenon to say that when people are hearing the message and they can see it in a platform that they are familiar with, it could change behavior. And then making sure that our services are not fragmented, that they are integrated to reduce stigma, to make sure that the confidentiality concerns are identified, but also to strengthen our referral systems. Next slide. So South Africa's response is a combination prevention approach. I've mentioned this as well, not just biomedical prevention, which is oral PrEP, as well as medical circumcision and injectable PrEP, but we are also looking at other structural and behavioral prevention methods. I mean, even if we just go back to the ABC, some people don't want the pill, others don't want the injection, others want to abstain, others just want to utilize the condom, and those methods should be made available. So we are working very closely with all our clusters in terms of CSE, as I mentioned, the integrated sexual and reproductive health rights, the rolling out of new prevention technologies, as well as making sure that we do not leave the boy child behind. I think when you look at SANAC's track record, ever since I've arrived, we've always had either a boys' imbizo or a boys' parliament on top of a men's gathering as well as a men's parliament, because we are saying a lot of focus has been on the girl children. So what about the boys? So it's a coordinated, evidence-based and people-centered response that addresses both immediate health needs and the underlying social determinants in terms of HIV, TB, STIs, and childhood and teenage pregnancy. Next slide. So, Chair, this is a slide that was presented last week at the conference in Brazil, and it really speaks to just how we've done it as a country. So the first one was what I referred to, Chair, around our performance on the 95, 95, 95, and the focus was that second 95, which is at 83%. In terms of the rest of the combination prevention interventions, on oral PrEP, which is the oral daily pill, since we started the program in 2016, we have distributed 2.27 million PrEP pills, and this means people have been initiated. But this number, Chair, does not speak to the number of people that are on treatment. Because as I said, based on, as mentioned earlier, Chair, based on pill fatigue, the exhaustion, the burden, the daily pill, clients are falling off and they are not staying on. LEN was launched by our Honorable President on the 6th of June, and the numbers as of this week are sitting now not at 26,000, but at 32,000. So we are initiating PrEP, the injectable PrEP. And then in terms of public health facilities that are offering PrEP, it's 99%. And if we go towards the right-hand side, since 2023, April, about 365,000 pregnant women have been initiated on oral PrEP. And this is important to make sure that we protect unborn babies, but that we also keep the mothers alive in terms of giving them access to antiretroviral therapy. And 91% of our facilities in public health are offering PrEP within the antenatal clinic, and we have expanded our comprehensive combination prevention interventions. So it's testing, it's post-exposure prophylaxis, pre-exposure prophylaxis, voluntary medical male circumcision, the STI services, condoms, prevention and treatment. And just by way of numbers, maybe I'll mention 2 or 3. We've distributed in the last year about 550 million condoms, male condoms, 20 million female condoms, and about 5.7 million people have been circumcised. And this is a good thing because this number speaks to a time when PEPFAR was starting to pull out and government was starting to conduct the circumcisions. We are doing still, as I said, quite well in terms of the testing of South Africans. Next slide. So, Chair, we are at a point now where I think I'd like us to turn to the structures that make SANAC more effective. And as much as we've given the NCOP a plan around the epidemiological evidence and the strategic direction, the success ultimately depends on how functional our structures are at national and subnational level. And we are going to talk to the committee now about our functionality at national, provincial, district, and ward, and provide really the committee with an objective and honest assessment of the functionality and effectiveness of this implementation structure. So I'll ask Mr. Leboa Malaka to come through to present these through to us. He's going to highlight some of the functionalities, some of the key challenges, and some of the key bottlenecks that we see, as well as some of the strategic interventions to strengthen their effectiveness so that we are able to implement a successful national strategic plan. So Malaka, over to you. Thanks.
Thank you so much, CEO, through you, Chair. Greetings to the members of the honorable members of the committee, and also my colleagues that are on the call. Just as an introduction to the engagement around the functionality of the AIDS councils, is that all the outcomes that have been presented here today, whether positive or negative, are somewhat linked to the functionality of the structures, particularly where the rubber hits the road at the provincial, district, and the local level. And I just want to also say that as SANAC, we operate through a coordinated single gateway architecture, aligned to the United Nations Joint AIDS Program, or UNAIDS in short, as 3 1's principles as outlined by the CEO at the beginning, of one authority, one strategy, and one accountability system. And with that, it suffices to say we are but one SANAC nationally, and as I'm starting, I will borrow from CEO's words also, where she always emphasizes that there is no place called national. Because if you look at national, what happens is that it's basically just putting together, guidelines, frameworks to enable implementation of the work to happen on the ground, including the development of the strategy. And I'm saying this carefully, Chair, in that these structures are not just a tick box exercise structures. They are necessary structures or necessary instruments that if we were to achieve epidemic control in the country, much of investment must really be put on these structures. So it is necessary that we get the structures functional, and on a regular basis, we monitor the effectiveness and the contribution of these structures into their own multi-sector response at each level, and which is basically what we are doing and what we're going to be painting a picture, an honest picture of, as CEO had said. So at national, what we do is we provide just that policy direction, because the structures are streamlined. All of the structures must ensure that they take the shape of SANAC and that they are aligned to also the mandate of SANAC, ensuring that all sectors of the society are mobilized. They develop, their own plans through a consensus-based approach, that they mobilize resources for the coordination of their response which is one area that all levels have really been struggling with, and then ensure the implementation of support for the implementation of the plan, including accountability or reporting on the plan. So this mandate really is a cabinet established mandate. And I must say, Chair, cabinet resolutions express most of the time goodwill. But what really enforces compliance is statutory authority, and which is what SANAC at this stage lacks. And I think you'll see as we continue. So our work overall through the councils is to make sure that there is that united front of bringing together government, civil society sector, as well as the private sector and the developmental partners. Next slide. So the next slide just shows the ecosystem of SANAC, sort of adding to what the CEO has actually expressed at the beginning. Just to say that the initial institutional arrangements and governance frameworks did not really outline clearly what should happen and how should the lower levels of SANAC, which is basically at the provincial, district, local, to the community level, be structured. So this ecosystem then starts to really frame that response so that we can demonstrate that we are all but one SANAC and that we are operating through a single gateway architecture, as I indicated. Next slide. So the leadership of the governance structures in the provinces is sitting at the highest political level, which is basically emulating what happens at national. As the DP or the presidency is leading the response. In the provinces, the premier's office is leading the response. In the local government, at the local government sphere, the district level, the executive mayors, and the local level, the local mayors. So, and at the ward level, then we expect that the ward councillors then are supposed to actually be. This is one of the levels that we are still struggling to really get to. You will get to understand why we are taking much time to really get there, because it requires really streamlined resourcing so that we are able to really, and sustainable resourcing, if I were to say. Now, there is also an additional support or an additional contribution or participation from private sector, with a recommendation currently that private sector should be added to have a meaningful contribution as equal and strategic partner in the response, and which there's a recommendation that private sector must be brought in as also a co-chair. If you look, because when you look at them, is that the premier will be chairing with the CSF chair, executive mayor will be co-chairing with an elected CSF chair at the district level, and so on. The reason for this is to really guarantee a commitment of community voices as well as business voices on the multi-sector response at that level. But our interest, Chair, is to really making sure that this work finds expression on the interventions that happen at the ground level, particularly government interventions. And one of the key instruments key intervention that we would want to link up with and make sure that we find integration and expression is the district development model, which ensures spatial budgeting and also shared outcomes. As it always say, one district, one plan, and one budget. So we're looking at making sure that we strengthen the multi-sector response through the processes. Next slide. Now, this slide just really paints a picture of how we constantly measure, the functionality of the AIDS councils, but it doesn't really outline really the actual indicators that we measure. What we present through these dashboards are high-level indicators because the assessment criteria itself has got a myriad of indicators. So when you look at it is an RAGP as or RAG system. If there's a red, amber, green measurement that really determines where each indicator is in terms of the functionality of the council. So the assessment criteria covers some of the following the areas, political leadership and regular quorum meetings of the councils, costed implementation plans, dedicated secretariat and budgets and their budgets, and then multi-sector and community participation, timely disaggregated reporting, corrective actions linked to program outcomes, inclusion of other sectors of the society. For instance, you have participation of civil society structures, participation of private sector, your development partners, engagements, and other related, relevant governance indicators or accountability indicators. And what we're seeing on these dashboards, in the previous financial year, you would realize that most of the councils have got a green, which means, or if not all, actually 8. They are reported as functional at the end of the financial year 2025-2026, but moving at the end or fast tracking to end of Q1 of the current financial year, which is 26-27. Already the councils, 3 of the councils are falling off. They have green, into an amber, which then tells you that there is a fluidity in terms of the functionality of the AIDS council, which requires to be constantly monitored and ensuring that necessary support is provided, including resources being available, including the political commitment that is necessary to drive these councils to seat in provinces and so on. So there is that need for that constant monitoring, but also for resourcing to ensure that these councils are able to meet and to deliberate on the multi-sector response in their own provinces. Next slide. Now, this just basically unpacks the amber and the greens on the dashboards that I've already outlined. When you look at the Q4, 8 PCAs were classified as functional due to fluidity and the risks that are there. Then you start to see the 3 AIDS cancers then falling out of the greens, as I indicated. And then at the district level, and we are implementing the district AIDS cancers only in 46 districts, which is the reason is that Western Cape does not implement the district AIDS council model. They are still exploring an integration of the work into the district health council. We're still waiting for a reporting from them in terms of how that is working. But however, our interest is into making sure that we standardize all work of SANAC so that we don't report on a comparative or a comparison of apples and oranges. We need to make sure that we're reporting on standard approaches. So at the district level, out of the 46 that are implementing, we have got 39 that are functional. And the good thing about the 39 that are functional is that we have got 36 that are led by the mayors, and some of the 3 that the mayors have delegated the responsibilities either to the deputy mayor, either to an MMC and so on. But however, we want this to be all led by the executive mayors overall. And then we've got 2 that are semi-functional and 5 that are non-functional, and we are looking at strengthening those to ensure that they are functional. The local AIDS councils are an area that really still requires a lot of, in investment into in terms of resources to strengthen them, but to make sure that they are functional, but also just that political buy-in at that level. Next slide. So the impact of strong political ownership and buy-in, as in line with our experiences on the ground, Chair and honorable members, is that where AIDS councils are backed by strong political commitment from premiers and the executive mayors, the AIDS councils functions well, and the multi-sector response really thrives. Then we're also starting to see inclusion of the response as a key program of local government, including the government itself, particularly at the provincial level. There's considerable localized allocation of resources for the councils, and we are starting to see a best practice that is emerging, which is incorporation of the council budget into provincial budget speeches. And some municipalities starting to pass budget votes for their own multi-sector responses on the ground. It's happening sporadically, and we need to standardize so that that happens, standard. But overall, Chair, for it to happen standard is that there must be some form of authority that is exerted over these structures, so that there is that kind of compliance. And significantly, there is higher sustained council functionality, consistent sittings of the council, stronger multi-sector participation, and also the 95-95 that Dr. Kulu was actually talking to, and dedicated and adequately staffed coordination mechanisms at the secretariats and greater compliance with our SANAC process. This is where the strong political ownership is and buy-in. And at some meetings, some sittings, when members of the executive council, the MECs are not there, or even the MMCs are not in the meeting will not start until they come, because the premier has got that authority over them, and exercises that authority. So it's some of the best practices that we really can share. The next slide. Now, what are the key systemic bottlenecks? Chair, as I indicated, there are, notable successes. But however, the coordination architecture really faces severe systemic vulnerabilities. And this one is because of lack of the statutory authority. Since SANAC was created through a cabinet decision rather than the act of parliament, so it lacks that statutory backing, which really compromises the work that we do, and we struggle then to be fully budgeted to enforce compliance and consequence management across stakeholders, as CEO has indicated earlier on. There is also absence of standardized funding frameworks in terms of how SANAC should be funded, because we are not established through a legal framework of government. So government has no standard mandatory funding allocation for AIDS cancers, to a point that some at municipality level, at the local government level, we are being told that the multi-sector response is not a core mandate of the municipalities, and therefore it's difficult for municipalities to really allocate resources for this kind of work. And then there is a dependence on the willingness or the cooperation of the political leadership in provinces, where there could be allocation of some discretionary budget for the council, which becomes really a challenge. And then we now even have a more serious vulnerability, in the sense that we've got donor agencies now withdrawing some of their funding, or funding really dwindling, which really poses a huge risk on the support of this work. Apart from that, is that we are also, as SANAC, responsible for the funding of the civil society structures. And it's a really bigger structure that has got a serious bearing on the budget of SANAC. And if SANAC cannot be funded for the shortfall that the CEO has alluded to, then we remain with a challenge where civil society finds it difficult to really express itself on the ground, and then focuses upwards and focusing on us in terms of those resources that they require to do their work. Next slide. I think the strategic interventions and recommendations is that we, in the absence of the frame of a statutory framework, Chair, we then have put together through the SANAC plenary resolution what we call SANAC standardization framework, a national multi-sector policy that we hope will give us an impetus to exercise accountability on the ground and ensure issues of consequence management. But for this framework to work, we will need a support of government at the cabinet level. But I think talking to a parliamentary committee now, we also feel that there is a role that Parliament can play and can influence in getting this kind of an instrument, so that there is that kind of authority, to exercise it. But the second thing is an issue of ring-fenced annual coordination budgets, that then for the National Treasury to have, established and dedicated ring-fenced, annual coordination grant for SANAC. And this budget must explicitly include delegated allocations for national PCA, DACs, LACs, and civil society operations to insulate this the multi-sector response. And lastly, inclusion of the structures into the budget planning of government, but particularly into the national and provincial budget speeches. And I think I couldn't really reiterate this more, as I've indicated. Next slide, Chair. So I will hand back to the CEO to complete. But Chair, as I'm rounding off from my side, we just like in a 4x4 relay, there's a tendency to really blame the last runner if we were to lose, and then to praise the entire team if we were to win. We are or maybe let me say, you are the last leadership before the Agenda 2030. And the chances are that we are going to be looking at this leadership to say, what have you done to get the response where it is at this stage of life? Thank you so much. Let me hand over to CEO.
All right. Thank you so much, Malaka. So, Chair, this is our last slide. And I'd just like, Chair, to say once more that we are grateful. We have seen that the architecture in terms of coordinating HIV, TB, STIs, as well as childhood and teenage pregnancy in South Africa is there. It exists, but what we need now is consistent implementation, as well as effective funding and political ownership at every level. And going forward, the issue of integration is no longer just a story. I happen to chair the Forum of National AIDS Commission Directors in 40 countries in Asia, Africa, as well as in Latin America. And Botswana, for instance, has changed the name of the AIDS Council to the National AIDS Health Promotion Agency, because it's a realization that even people living with HIV are living longer, and they're no longer dying of HIV, they're dying of things like diabetes and hypertension. So the coordinated approach and integrated approach is an important one, and one that we're working on, especially as we move towards universal health coverage. Integrating the response into the district development model, I think I could not have said it better than Malaka did, because we know that even when the Department of Public Works, for instance, builds a bridge so that children can cross a river to get to a school, if a girl child crosses that river and gets to school, school has a protective effect in terms of acquisition of HIV. And then making sure that we've got differentiated approaches for different populations, looking at the burden, the age groups, their geography. It cannot be a one-size-fits-all, but it has to be evidence-based in order for it to be effective. And then also strengthening the coordination system, making sure that there is secure political ownership at every level, the statutory authority of SANAC, and ring fencing funding for that in order to make sure that we are able to be held accountable, but also that we are able to hold other structures accountable. The key asks that we have, Chair, before I make a last closing remark, is to ask for the support of the committee in terms of making sure that the two plenary resolutions that were taken, that all SANAC IMC departments contribute to the operations of SANAC, are carried through, to make sure that political leadership of SANAC at all structures actually takes it seriously, and that SANAC structures do meet and do achieve the mandate, because the National Strategic Plan gets transmitted into provincial implementation plans, and those then become transmitted into multi-sectoral district implementation plans. So every level has got a clear plan with clear targets, etc. But what's missing is the resourcing side of that. And then from the chair, we also are requesting assistance in terms of launching the remaining TB caucuses. But Chair will remember that we only managed to launch the TB caucus at the National Assembly, and we haven't launched at NCOP level. So Chair, as I end, I would like to say that coming back from the International AIDS Society conference in Brazil, the feeling is that the world is not on track to meet the 2030 goals, because we have all been talking about ending HIV as a public health threat by 2030. And as much as the world is not on track, it's because of multiple reasons, whether it's unprecedented funding cuts, other emerging health priorities in other countries, growing inequalities, some of the disruptions that we saw in terms of prevention and treatment. But the science, Chair, has never been stronger. And if government, communities, and the private sector act now, act boldly, and act decisively, there's no doubt that we can end AIDS as a public health threat by 2030. Thank you very much, Chair.
I just want to thank the CEO and the team for the informative as well as detailed presentation from your side. And we take note of the special requests to the committee, and we will surely see to it that we respond to that. So, honorable members, we have received the presentation. We will now move over to the discussions. I can see Honorable Sibande is already in line to give his contribution. Then Honorable Du Plessis, Honorable Mampuru, Honorable Kennedy. So we will move in that order. Honorable Sibande, over to you.
Okay. Thank you very much, Chairperson. I wanted to thank the department and also everybody who have contributed in this deliberation for the day today. But nevertheless, we'll have seeking questions. Like number one, what direct role does SANAC play in addressing broader socio-economic challenge, such as poverty, unemployment, and gender-based violence that increase vulnerable to HIV and STI? Second one, what key policy, legislative, of budgetary matters does SANAC wish to formally bring to the attention of the community for oversight and support? And then another one is that what in innovative youth-focused strategies is SANAC deploying to encourage youth people to delay sexual debut? But the last one, maybe it can come again. I wanted maybe to request for the presenters so that they can assist us. I know it can be a repetition of my question, that they've indicated that there's no standardized government funding. It's concerning me that, you see, I'm very much concerned about it. I need them to elaborate more, because I thought that they are getting assistance from the government. But if they are not getting assistance from the government, that is something else. I need a clarity on that one. What do they mean exactly, and what can be done so that they can able to intervene to assist them on that one? Thank you very much, Chairperson.
Thank you very much, Honorable Sipande. Honorable Du Plessis.
Thank you very much, Chair, and I just want to say thank you very much to the council. This is, as I've stated many times, a very important issue, and I do appreciate that they have gone internationally to get best practice. It was one of my initial questions to find out what exactly is the best practice that will be implemented, and which countries, developing countries, have successfully been able to minimize their AIDS rates. I do also want to say the one of the officials mentioned the fact that the model is not followed within the Western Cape, and I do not want to politicize. I do just want to say factually the HIV and AIDS rate is the lowest in the Western Cape, which is then the question as to why is it the lowest in the Western Cape. From what I understand is the Western Cape Health Department does additional work over and above PrEP, but also does counseling and voter education within various communities. And are we able to do this in the rest of the country as planned and also within our legislation? I do also want to ask a question. HIV/AIDS and all other STIs come with GBV, and what exactly are we doing to address GBV, as well as the linkage to GBV and psychological elements within society, such as drug abuse and the reason I'm asking it, and I should maybe be more clear, this problem is a whole of society approach, and what exactly is stopping the council from having a whole of society approach? And I don't think the issue necessarily lies within the council, but the council asked us for various interventions. What intervention can we do as the NCOP to ensure that there is a whole of society approach, and what parts of society need to play a role within the minimization of HIV/AIDS? There is also a mention of both the boy child and the girl child. I think it is incredibly important that awareness is created not only within the girl child, but also within the boy child, and the responsibility that comes with being with being a human within society, whether you are male or female, the responsibility of testing, the responsibility of ensuring that you use prophylactics, that you are not just using prophylactics, but you are also using condoms and femdoms and all of the sort. There's quite a large amount of femdoms that have been given out. However, I do believe that femdoms are also size related, as condoms are as well. And what is being done to ensure that the correct femdoms are given to the females that are actually accurate, not accurate, but actually fit them and actually ensure that there is a resistance or there's a stoppage of HIV continuation. I'm also quite concerned that there isn't a lot of mention with regards to drug abuse and alcohol abuse within this, as it also plays quite a large role within HIV and STI spreading. But the main question is what exactly is needed that we ensure there's a whole of society approach within this crisis, especially within our young girls' lives. Thank you very much.
Thank you very much, Honorable Du Plessis. Honorable Mampuru.
Thank you, Chair, and also greetings to yourself, honorable members and the team. Chair, let me, on the same note as other members, welcome the report. It's a very comprehensive report and it is also very informative. I just have a few questions and also contributions which I would like to throw in. Chair, if you might remember, in the late 90s and also in the early 2000s, the Department of Health used to have programs which were directed into educating communities about these issues which are raised in the report, of HIV, substance abuse, teenage pregnancy, STIs, and all them. But for some reasons, as time goes on, those programs were reduced for any reason which might be known by the department. For example, we used to have a program which was ran by Love Life in places like Jenfest in Chatulanang. They were properly funded at the time, and it used to keep youth very busy and move them from a straight to be engaged in wrongdoings. For some reason, that initiation has been closed down. The program itself is no longer funded. The building which was meant specifically to deal with these issues which we are facing today has dilapidated, and HIV and AIDS community outreach have collapsed, which led to the challenges that we are facing today. So I would also want to check with the department whether they have any plan in place to revive such initiatives where community, in particular young people, will be kept busy, will be educated on issues of HIV and AIDS, drug abuse, and also teenage pregnancy. That's number one. Number two, Chair, we have programs which we're dealing with also these issues, programs like Humana, which give support to, sex workers. We have issues, programs like climate change, which are mainly based in Eastern Cape and KwaZulu-Natal, which the report have just told us that they are the highly affected areas when it comes to HIV and AIDS infections. These are the programs which are making efforts into educating our people in the challenges that we're facing. However, they have been defunded. The last one, Chair, there is a crisis when it comes to home-based care workers, in particular in townships and rural areas, who goes for months without having received their stipend, whereas they are expected to go and do their work on a daily basis. These are the challenges which are contributing factor as to why we are unable to cap the infection of HIV and AIDS in our society, because even the department itself does not take care or look after the people who have made it their business and their responsibility in educating our people, making sure that those that are taking medications do not default, and encourage our people to go and test. So I would want the department to highlight on these issues as to how are they going to address these challenges which our people are facing, in particular, this one of the home-based care workers who are dealing specifically with those that are taking medications, those that must be given their medications at home. Lastly, Chair, there was a team from KZN, which I think 3 years or 4 years ago was taken to Zimbabwe to be trained on the same issue that we are discussing. And then upon their return, at least less than 50% of them were absorbed by the department, and all of them that were remaining were left to go home without any responsibility. So I'll also want to check with the department as if, whether they have a plan in place to integrate those young men and women who were trained in Zimbabwe on the issues of HIV and AIDS, so that they will be able to assist the department, in particular our people, on these issues and provide support to both government and also our people at the grassroots level. Thank you, Chair.
Thank you, Honorable Mampuru. Honorable Kennedy.
Thank you, Honorable Chair. Let me also welcome the presentation. I've got only 2 questions here. First, statutory rape and intergenerational sexual activities are the main or remains a primary driver of both teenage pregnancy and HIV transmission in young women. So what I would like to hear from SANAC if there is any involvement with the law concerning this. How is SANAC collaborating with the justice and social development sectors to strengthen law enforcement against statutory rape and financial exploitation of minors? And secondly, most of our young girl child, are now afraid or reluctant to go to the clinic to ask for help because most of them are being ridiculed or belittled when they go there to seek for help for maybe STI, etc., etc. And while SANAC frameworks advocate for youth-friendly services, end-term reviews frequently cite clinic-level discrimination and judgment by staff as major barriers for pregnant teens and youth seeking STIs contraceptive care. What structural steps is SANAC advising the Department of Health to take or to penalize or retrain non-compliant healthcare workers? Thank you.
Thank you, Honorable Kennedy. Honorable Fanny.
Thank you very much, Chairperson. Let me take this opportunity also to greet honorable members and indeed the SANAC CEO and its leadership. Mine, Chair, I think just first and foremost to appreciate the presentation, indeed, which is informative and indeed at the same time it does have an element of a capacitation also in terms of to myself with regard to what our societal challenges were related to AIDS pandemic currently is confronting us as a generation. Mine, Chair, first and foremost, just to comment the work that have been done because it is not as easy as one might want to understand, you know. But we see the progress in terms of the you know, in terms of how you know, their programs are impacting in terms of awareness, and then also the management of you know, spread, you know. But the question that I'm having, Chair, you know, as Honorable Du Plessis have alluded that, look, there is, you know, some progress on the side of the Western Cape, which is it is factual in terms of, you know, scientifically, you know, proven through the you know, their research. But my problem, I mean, my question now to directly is why are we not utilizing, you know, our research mechanisms that we are utilizing in the way in the Western Cape just to learn, you know, what we call a good practice in order to affect, you know, all the other provinces, so that whatever mechanisms that we are utilizing at that level, whether it's the question of your financial resources, if additionally, as she alluded to, Honorable Du Plessis, that there are other mechanisms that are, you know, a contributory factor in what is already provided by the national government. So I just want to check, you know, why is it is not, you know, the case, you know, and also the question of socio-economic challenges that uh, are differing, you know, in different provinces, aren't they also contributory, specifically when you talk about the Eastern Cape and KwaZulu-Natal, where, you know, the province vastly is rural, and also I think it's Limpopo indeed. Those provinces are rural, and then also high level of poverty and unemployment. You know, and they contributor in terms of the high statistical numbers that are, you know, that are not improving, but you know, and then also what is the is the influence of cultural and then religious practices in those areas, you know, and they also contributory, because I know, you know, my people in those provinces were still, you know, in huge belief in those practices, which somehow, you know, were left behind in terms of whether technologically or your other, you know, developments that relates on new forms of approaching the reality. Uh, I just want to check, you know, when I'm trying to balance also, if they can also, you know, input on that one, because the question of condoms, female condoms, I forgot its name. It's not something that is, you know, in our vocabulary up until this day. You know, I believe that this is have been there for too long, but you really rare you rarely hear, you know, even you know, leaders who are talking about you know, female condoms. So you know, what awareness programs, you know, are we enforcing to ensure that when it comes to the question of protection, it does not only rely on males, and as we are all agreeing that males sometimes, due to their financial status in society, are also the ones who are determining, you know, during those interactions, which directions to take, you know, because if one is in a you know, advantageous position, then that person becomes an influencer, or becomes determines, you know, which way to go. So make an example of a condom use now when it comes to the question of, when that time comes. So how do we balance, the two, and also why there is no strong awareness programs specifically related to the female condom use. The last one, Chair, I think on the question of, I think it's PEPFTA, is this where PEPFTA that was mentioned to have withdrawn, its contribution or support financially. What were the reasons that led to that, and the impact that have caused? Because I see on the financial that you are still limping a little bit, but on the minimal that you are having, you do have at least managed to achieve thus far. Thank you very much.
Thank you, Honorable Feni. There's no other member who wants to have a bite on the presentation, so I will just give my inputs in the presentation. CEO and the team, I saw on one of the slides that the council have indicated the country has approximately 160,000 new infections in the 2023-24 financial year, according to Tempisa. My question is this the latest updated numbers, or is there other stats available in terms of this new infections? Because 23-24 is really a long time ago now at this moment, because we in 26-27 financial year. And then in terms of the vulnerable and key populations in terms of HIV and AIDS, to what extent are vulnerable and key populations, for etc., sex workers, sorry, the LGBTQIA being prioritized within the current national strategic plan? And then in terms of Honorable Mampuro and Honorable Fene have touched on it, the awareness campaigns, like I think the CEO have indicated with the polygamist serious thing that came out after that, the utilization of condoms increase. If the council can team up with the NDA, because I have saw we know that the mandate of the NDA is to create jobs, especially under the youth. If we can team up with them and forming groups that can go and do acting especially for the younger learners, especially at primary school level, and we can take it to the secondary level, so that it is when we as people see what can happen, we can relate to it. It's not about do as I say, it's about do as I do. So that is all from my side, CEO. We will give over to you to respond.
Thank you. Thank you so much, Chair, and thank you to the members. I think very thought-provoking and very insightful questions and comments, and much appreciated. So I'm going to just divide it for my team members so that we don't leave anyone behind. Apologies, members. So Zwebuga, I'm going to ask you to please touch on the issue of the Western Cape, but also speak to the issue just of the numbers in terms of Tembisa and how we decided to frequent a Tembisa. And then Nelson, I'm going to ask you to please touch on the love life that I think Honorable Mampuru mentioned. I will speak to the issue of the community health workers, and then Dr. Roger. I'm just going to ask you to speak to Honorable Sibande around the broader socio-economic challenges and how we are working with other departments in addressing things like GBV, etc., etc. And then from Malaka, if also Roger, sorry, if you can also touch on just outside GBV, the work that we are doing also with DSD, CDA, on the people who inject drugs or are living with drugs, and also that whole issue of alcohol, etc. And then Malaka, if you can then touch on the issue of the key policy and legislative support that we are looking for in terms of how SANAC was set up, and what we are asking for in terms of the committee for assistance. And then in Tabiseng, if you may please respond to the innovative youth strategies that we have looked at as a country, and then I will come in and fill in on whatever has been left behind. So let me then ask Zwe, would you like to start? Or should I start with Nelson? Nelson, let me start with you.
Thanks, Theo. Thanks, Chair, and thanks to the honorable members for the questions. I am going to address the ones on awareness campaigns, social behavior change, the likes of love life, etc., etc. Some of which the CEO touched on in the presentation. So starting with the quick one, love life is still there, but it is also subject to limited, severely limited resources, and a robust social behavior change campaign requires sufficient investment. And without sufficient investment, there's very little you can do. If you turn on your TV, for an example, and look at how much advertising the likes of Outsurance does, the likes of the funeral, it just escapes me now, but the funeral cover that is done by the actress Lillian Dube and Desmond Dube, it's always in our faces, and we can almost recite the lines that they're going to say. Clientele, yes. You can almost recite the lines that they say, because they invest, the companies, their biggest budgets on all expenses is on marketing. And that's what we lack. Whenever there are fiscal adjustments, budget cuts and what have you, the first place to cut is always on communication. So there's very limited investment into that. And even when you look at Komanani, what made it a success back then, in the early to the mid 2000s, the investment into that was in excess of 150 million. And all of the sectors were mobilized, the private sectors were mobilized, audit firms were in on it, PR agencies were in on it, pro bono on top of the investment that were there. So we have created strategies. For instance, we had the She Conquers strategy to address the high infections among adolescent girls and young women in the previous cycle of the NSP. We then transitioned from that to the Zikalaganjani Youth HIV Prevention strategy and campaign, which was now an inclusive, taking from She Conquers, this one was now an inclusive strategy addressing both adolescent girls and young women as well as boys. But we've struggled to really push them for maximum impact because they weren't funded. A strategy can be created, it can be brilliant, but if there's little to push its implementation, then you have challenges. We saw how the budget, the mere operational budget of the trust, which supports the council, our budget is so severely limited that when it comes to communication, there isn't even much that goes towards. We virtually have nothing to do anything. So what we can do is leverage on partnerships and reach out to those that can assist in pushing certain strategies. And then in terms of the storytelling approach, it's a proven, I think it was touched on by Honorable Finis as well as Honorable, a few honorable members have touched on it. Through storytelling approaches, you can achieve quite a lot. I mean, we saw the conversation that erupted after the famous series on Netflix. The famous Jonasi is probably the most famous male name right now of a fictional character. And that's how much you can achieve through storytelling. So we know the evidence is there, but then again, it comes back to the issue of investment. When you partner with production houses, there needs to be a production budget for them to even listen to you. When you approach existing soapies, for instance, even through the SABC Foundation or SABC Education, you have to come carrying something because these are owned private businesses. In as much as it may be on an SABC platform, the SABC has paid for it, and there are strict contractual agreements that are in place. And for you to be able to penetrate that and be listened to, you have to come up with something on hand. So I think at the, and of course, we take note of the suggestion from Honorable Finis to rope in the likes of NDA and approach them. There is an SBCC technical task team within SANAC under the technical task teams that the CEO showed on the organogram. This is a structure that is made up of industry experts, including people that were in Komanani, including the likes of your Lebo Ramafukus, who drove a lot of these back in the day, as the honorable members may recall. And now they provide strategic guidance in terms of what to drive when it comes to social behavior change, how to approach the implementation of certain campaigns, etc. And through that structure, we are hoping to really get to a point where we resuscitate yet again something that will be to the level of Komanani, and to continue again to increase partnerships that can help us mobilize the whole country and all sectors in trying to resource and drive a comprehensive national SBCC campaign. I'll stop there. Thanks, you.
All right, thank you so much, Dlamini. I am going to then ask Zwebuga to come in on the strategic information related questions, especially also the question from the chair in terms of how outdated is the current Tembisa data that we put forward. And anything else, I think, Zwebuga, that related to the numbers. Thanks.
Thank you very much, CEO, and a good day to the committee members. So maybe I'll start with the performance of the different provinces, specifically looking at the Western Cape, and as it has been indicated as one of the best performing provinces that we can learn from, and replicate what is being done in the Western Cape province and other provinces. So I'll start by mentioning how actually different components of the performance indicators are performing in different provinces, looking at the dynamics and the differences thereof in all and all the provinces that we are looking at. So specifically, if you're looking at the progress against the HIV 95 targets, which are talking to 95% of people living with HIV knowing their HIV status, as well as the 95% of those that know their HIV status being put and retained on treatment, and then 95 of those that are on treatment being virally suppressed. If you're looking at the performance on the Western Cape province is actually amongst the lowest performing provinces when it comes to those. Currently sitting at about 95% of people living with HIV knowing their HIV status, but not doing so great in terms of putting and retaining them on treatment. It's currently sitting at about 81%. Of those that are living with HIV being put and retained, those that know the HIV status being put and retained on treatment, and 94% on those that are on treatment being virally suppressed. So indicating that the initiation on treatment and retention on treatment is not doing so great in the Western Cape province, specifically amongst the other provinces. But what I can indicate that is visible in terms of performance and progress thereof of the Western Cape province amongst other provinces is the fact that the spread of HIV itself is not as high as it is in other provinces, where you look at the social and structural indicators performing slightly better. So that puts Western Cape slightly in a better position when it comes to spread of HIV, but the risk is still as high amongst the provinces that are there. If you're looking at the amount of people that are put and retained on treatment and are also considering treatment as prevention for the spread of virus. And also, if you're looking at the Western Cape province specifically against other provinces, it is a high proportion of people that are living with HIV that are not confirmed to be virally suppressed, which also increase the risk of the spread of the virus itself. So there's quite a number of dynamics that are contributing to that, but just to indicate that it is amongst the lowest performing provinces when it comes to coverage on people that are living with HIV that are put and retained on treatment. So we talking to the issue of the Tembisa and the latest data that we are utilizing. So we do have the Tembisa model that is basically covering quite a number of indicators that are helping us monitor the progress of the country thereof on critical indicators on HIV and how those are doing, and the frequency thereof is that the release of the model itself or the result thereof is actually on a yearly basis, and then from there, as years goes by, we are then able to use projections to actually look at the performance towards projected performance using predictive analysis towards maybe at the current moment we have projections up to the year 2035. But as we go along, we then confirm what has been projected by the model itself with the program data that then becomes available, and that becomes our reliable source of reporting. Hence, the reported numbers may be dating slightly backwards, but there is data that is available, but we're just ensuring that the program data actually confirms the projected data that we then have on our models, so that we are then able to monitor progress thereof. I'll pause there for now. Thank you.
All right, thank you, Zebuga. Can I then ask Dr. Roger to come in? Dr. Roger, I think you are going to speak to some of the questions that came from Honorable Femni regarding PEPFAR, as well as one of the first questions from Honorable Mampuru on sort of from Honorable Sibande around what actually like support are we asking for from a policy, legislative, and funding side. What are we asking them for? Thanks. Dr. Roger?
Thank you, CEO, and thank you to members. I think our responses are kind of cross-cutting and overlapping. So yeah, I will touch a little bit also on what my colleague Thabiseng is going to cover. just on how we are also involving the other departments. So the NSP that SANAC is implementing is based on a people-centered approach, which means that we need the whole of government and the whole of society to be able to be effective in implementing the NSP interventions. And I've just found one slide there that I've projected just to make an example of this age group that the members are concerned about, the age group 10 to 24, which as CAO has already indicated that the epidemics disproportionately affect the young girls. So you can just see from that example, if you follow the diagram there, that the catchment services happening in schools, in communities, in the form of safe spaces for those girls or young people that are no longer part of the school-going community, which, by the way, is where you will see the highest HIV transmission, because most of those are not in education, not in employment, and they are nowhere to be found. So hence then those community safe spaces are part of how then SANAC works with the civil society to set up departments, the areas that the young people can get services. Some are victim of GBV, so they will be referred through the Tutuzela care centers with the specific programs that we work with police as well as Department of Justice and the others for those victims of GBV issues. And then DST also have got their own centers for people who abuse drugs and the others, just as much as also we work with the higher education sector for the population that is mainly at TVET, but also at other institutions of higher learning. So in that example, you can just see that from the catchment perspective, the services involves the communities as well as the other department in terms of identifying people that are eligible for services. So in terms of all the other diagrams, it's just to show, because we did not have much time to deliberate on the specifics of the combination prevention approach that CEO talked about. But just in a nutshell, you will see there, all of these young people will go through the risk assessment, given that fact that we can't use a silver bullet approach or one size fits all. So each one will be assessed based on what their vulnerabilities look like. But all of them, for example, will then receive a core package of services, which things like HIV tests, condom education, any young person that enters health service, whether through education or through any other means. I'm not going to go into the details in terms of the packages, because in this combination approach, prevention approach, you can see for health, it involves everything from HIV testing, TB screening, even things like termination of pregnancies, and everything is offered to the young person. And that is complemented by the behavioral interventions, which then it's other departments that are also coming on board there, DST and the others. And you can just see, just from the programs that you were seeing in that block, this is a comprehensive range of behavioral interventions that can be given to young people. And I know that one of the members also was asking about the boy child. It's not forgotten, because you can see that there are programs there that are aimed at the boys, things like circumcision, for medical male circumcision, by the way, are then part of the packages that are just designed for the young men. But it's also just to highlight there that everything is risk-based. We know that the young girls are embarking on relational relationship, having sexual partnerships with older men. So for older men, you will find that there are structured packages, for example, the male sexual partners, because you can address the problem with the young girl, but if the person that is infecting the young girl even though all men will be offered services, but there is a target for the male sexual partners of the young women. And then maybe just lastly to say that for the structural, you can see that the services that are advised in the NSP includes everything else, even GBV and interpartner violence awareness. There is dialogues that are held in the communities, like with the traditional leadership in some of the settings, to sensitize the members or the leadership about issues affecting young girls and youth in general, to address vulnerability issues. Hence, then, to answer that question of the whole of society and the whole of government approach, this is just an illustration of how in the NSP then SANAC ensure that coverage is given widely. I think it's Honorable du Plessis had some few questions relating to these specific things. But in terms of the other departments also that we work in close relationship with, there are critical ones. I've already indicated the police and justice in terms of the GBV issues. But then also you find that with the police, most of the key populations, the vulnerability is promoted through those legal enforcement. I think the members are aware that to practice sexual, the sexual practice is not legal, and hence then there are issues with, regarding law enforcement and those kind of key populations. Sometimes they can round it up. The ARVs are confiscated. There's evidence and those kind of things. So part of the intervention is that then we work with those departments to sensitize police. So through the Global Fund, we in the last grant were able to train more than 5,000 police members, not just subs, also the ones that are municipal based, like COJ and the others, just on how to deal with the issues relating to key populations, even the people who inject drugs and sleeping under the bridges and so on. So those are just the example of how we work with Department of Correction of Social Development. They run a lot of spaces where people who abuse or inject drugs are found, and hence we work on programs like the methadone to provide services for people that are injecting drugs to infections, as well as addressing the whole issue of substance abuse. So those are just a few examples. And then lastly, yes?
No, I was
Okay.
saying, Roger, it's okay because I've gotten Tabi and Nozugo who will also speak.
Yes, all right, yeah. Let me move then to the one on the funding. So on the one for PEPFAR, it is true that PEPFAR has withdrawn. I think the reasons that were cited, we all are aware that it was as part of the executive orders that were issued by the US government. It wasn't only the health-related services that were affected, but also PEPFAR was funding quite a lot of research-based programs in the country, as well as even crutches. Some of them were funded through PEPFAR. So all of those things were affected as a result of that executive orders, because the PEPFAR funding contributed significantly to the HIV and TB response in the country. 24% of the funding for the NSP came from PEPFAR. So that is the funding that is now lost. Initially, it was gradual because they retained a little bit of the services through the legal action that was taken in the US. But now there already has been a resolution that everything will stop to exist from March 2027. So then this then places the pressure on the government to be the main funder of the services. But not only government, because we are also trying to develop a strategy where we are also getting the private sector to meaningfully contribute as well, because the government on its own is not going to be able to cover every cost that is required in terms of these services. So SANAC is working on that strategy, domestic resource mobilization. Obviously, the Treasury will still be the biggest funder, but we expect that most of the gap left by PEPFAR will be covered by the contributions from the private sector. The main services affected, that's why I was dwelling on this slide, because most of what you see in this slide for key populations, PEPFAR was very good in providing those services. If you look at the outreach services that needs to go to the key populations, that is where PEPFAR was strong at. Not that the Department of Health can't do it, but we were talking about the differentiation of services. So if you have somebody that is sleeping under the bridge and injecting drugs using the same needles, there is limited capacity from the local PHC to be sending a mobile service to those people. Whereas you have got organizations in the community that have skills and capacity and specialize in those kind of key populations. And that is where PEPFAR funding largely contributed to those organizations were able to receive funding from them. So that is where we are seeing a lot of impact negative impact in terms of the PEPFAR funding. On the SANAC one, I think it's Honorable Sibanda, yes, there is no sufficient funding. The funding there's only two departments, as CEO was indicating, that contribute. It's DST as well as DOH. And as it was indicated, it's only 60% of what is needed. Hence, the rest of the fund we then raise from the donors, which is not an ideal situation as was indicated. So there is definitely a need in terms of our main ask to ensure the effective functioning of SANAC is that that resolution which was already taken at the plenary, that all other INC departments need to contribute to the functioning of SANAC is the main support that we are putting forward. And we have worked out that it is not really a big financial burden, because if you take the budget of 101 million that is needed per year at SANAC, our previous calculations amounted to less than 0.1% contribution from each of those departments. So we believe that it is a negligible amount that can be contributed by other departments to ensure that SANAC does its work effectively. Thank you, so I hope.
All right, thank you. So thank you so much, Roger. Chair and honorable members, we are aware of the time. I think we've got until 12:30. So with your permission, we'll only use the next 10 minutes. We do have our key link to youth programs, as well as our key lead in terms of the relationship that we have with the Department of Social Development. And I think this is where issues, for instance, related to alcohol and drug abuse and gender-based violence comes in. So I would just like to give them a few minutes also to give their reflections. So can I start with you, Ntabiseng, from the youth? Thank you.
Thank you so much, CEO, and good day again to the honorable members. From my side, what I would like to also start on is that, as it has been previously mentioned, that SANAC is multisectoral. So we make sure that in whatever that we are doing, when we are talking about youth engagements, we invite all the departments that are working with young people, just to leverage on the spaces that they actually cover. I'm talking about Department of Basic Education, because we know most of our young people are in schools, whether it's basic education or higher education. And then we also make sure that we also touch on social development as well, just so that we make sure that all those departments are also part of the conversations, they are also part of the solutions as well. So I'll talk to the specific innovations that have actually been done or coordinated through SANAC, just to make sure that we also have a hand with regard to the HIV reduction, teenage pregnancy reduction, and also impacting on gender-based violence. So we have youth-centered prevention programs that we have been coordinating, specifically the one that Nelson has touched on already, Zikhala Kanjani, which was very effective, which promote age-appropriate youth-friendly messaging that talks about a healthy relationship, life skills, self-efficiency. Like it talks about multiple things that actually affects a young person, and then also integrated combination prevention, which is also very important to make sure that the messaging that we are talking to young people are not only health focused. We are talking about combination prevention, behavioral, structural, and all those other areas that actually young people are also looking at as well. And then the most important one as well is the meaningful youth engagement. We have realized that it's very important to make sure that whatever that we do or we plan for young people, we have to make sure that young people are at the center of everything that we are doing. So we make sure that we involve young people in co-designing campaign policies, intervention, everything that we are doing. As long as it's about them, they also have to be part of them, because they've always mentioned this to say that nothing should actually happen for them without them. And we make sure that that is actually at the center of everything that we are doing. And we also support all the other departments that have youth focused program. I'll give an example of a comprehensive sexuality education that is done under the Department of Basic Education. We make sure that Department of Health also has a voice in that as well, so that we don't do parallel engagements, but we make sure that all the departments that are involved are there as well. And then the other one is peer-led approach, making sure that young people are actually motivating each other. They are champions in all this. And then the other very important one is parent and caregiver engagement, because most of these things that we do will engage young people, forgetting that young people are not living in silo, they are not living in vacuum. They do have parents, they do have caregivers that if they are involved and they also understand, they will also be very important in making sure that whatever that we are trying to get to, they are also having their hand in. And then the other one is the digital innovation. We know that young people are in digital platforms, social media, and all those. So how do we make sure that everything that is being done, all the programs that we are doing, we take them to where young people are, so that they don't actually have to divert from what they like to actually get all these messages. So we try by all means to work to make sure that we actually get young people where they are, so that they can actually get all these things that we are doing. So I'll pause there, CEO, and hand over to Nozuko
Thank
to
you
also
so much.
add. Thank you.
Thank you. Thank you so much, Nabiseng. Chair, so Nozuko is our link to the Department of Social Development. So a lot of the work that we do with them related to them being a custodian for children, but also in terms of alcohol, drug abuse, as well as GBV. So Nozuko, if you can just briefly touch on that, I would appreciate it. Thank you.
Thank you, CEO. Good morning, good afternoon, Chair, honorable members. Yes, South Africa, we know that our epidemic is driven mainly by gender inequalities, and the fueling of these inequalities are actually rife in vulnerable populations. And I heard the honorable members asking us about the key populations, which is another group that we work closely with in addressing these inequalities. And how they manifest themselves as social and structural drivers. Thus, we are working with different departments, mainly the Department of Social Development and also the Department of Women, Youth and People with Disabilities, and other departments, of course, because of the intersecting nature of this epidemic with, for instance, with GBV, gender-based violence, and also other issues like drug abuse, issues of mental health, and then we'll be working with Department of Social Development on those issues. So what we have been doing, as much as we have got two strategies, we've got a strategy on HIV, TB, and STI in the country, as well as strategy on gender-based violence. What we have been doing with Department of Women, we looked at the both strategies, and we saw the intersection and the interlinkage of these and how they are fueling each other. And furthermore, they knew the first GBV survey that was recently conducted and published actually demonstrated to us, when you compare the data that is coming from Tembisa model and the data that is coming from the subsum, which is done by Department of the Human Resource Research Council, as well as the GBV, the data from GBV survey, you can see the intersection, and we've analyzed the data from these three sources to have an understanding of our own epidemic in the country. And then the other thing that we're doing with social development, we work closely with them when it comes to issues of substance abuse through the Central Drug Authority, where we look at how drug abuse intersect with HIV, TB, and STIs. And we have a technical task team that is chaired by a Deputy Minister from Justice and Constitutional Development, Honorable Andre Snell. That technical task team actually is looking at all these social factors and structural factors that are fueling the epidemic in the country. So on quarterly basis, we have a discussion and on the interventions that are being implemented. One of those is issues of human rights. So we look at different human rights violations. We look at issues of GBV, we look at issues of mental health as they are emanating from the communities, and they are reported on quarterly basis. And also with social development, we also work closely with the directorate that is managing the Child Protection Register. And with the Child Protection Register, we want to make sure that the perpetrators of violence are actually captured in that register, so that anybody who's working with the child or with children, actually, if that person is a perpetrator, at least we know they are registered in the register. This will include even our own educators. So on monthly basis, there are webinars that are conducted through a knowledge hub by Department of Health that is looking on the issues of a child protection register, so that everybody who interact or interface with children in the country is a person of integrity, and she doesn't have any dark mark in terms of abusing children. So we work closely with that directorate within the Department of Social Development. Furthermore, we know that in social development, they've got a command center. So within the command center, what we have done, because they were focusing mainly on GBV, whereas we know about this intersection, what we've done in 2 years ago, we've trained the social workers also on HIV, so that they understand that these epidemics actually they influence each other. So those are some of the things that we are doing both at strategic and programmatic level. And we have started working closely with the research institutions, especially when it comes to issues of children. For instance, the Children Institute at UCT. So the child gauge that is being released by the Institute on annual basis. So our members, our stakeholders, actually, they get the report and look at how children are affected in the country. Just to cite one example, we're looking at the facilities in the Eastern Cape. And one of the things that we have seen of this intersection is child and teenage pregnancy, high level of child and teenage pregnancy, just looking in the health institutions, malnutrition, the acute malnutrition that comes with it, and also the HIV. So there is always a correlation. So if you see Eastern Cape having a high teenage pregnancy, what happens is that when you look in the same region, you'll see that GBV is actually very high. Issues of statutory rape are high. Acute malnutrition on children are very high. The termination of pregnancies within the facility and those that are done informally outside the facilities are very high. So we are starting to come up with a story to say what is it that is actually happening in these communities as we are dealing with multiple epidemics in the country. Thank you, Chair, and thank you, CEO.
Thank you so much. Thank you so much, Nozuko. Chair, with your last permission, I'd just like Mr. Malaka to close in on the legislative issues that were spoken to as well. So Malaka, just 1 minute, because I would like us to give honorable members maybe a chance to come back based on what we have put forward. Malaka?
Thank you so much, CEO. Yeah, and the chair. We on the issue of pieces of legislature, and I'm going to be honest here, Chair. The fact that we were not established through a legislative framework means we go around scraping for pieces of work or policy or legislation or policies that can support us. We know that it was SANAC was established through a cabinet decision. Today, as we sit here, as I sit here, we haven't, none of us has ever seen the that cabinet decision or that cabinet memo, what it entails, what piece of legislature were used, and so on. So we're scraping around. We're looking at pieces of the constitution, some subsections that we can leverage on. We're looking at powers and functions of the cabinet committees. We're looking at intergovernmental relations framework, and we're borrowing all over just for leverage. And I think this is what we really want corrected. And so that is basically a challenge. And looking even at what Roger, my colleague Roger, had said earlier on around funding, you can see, because there's no standardized framework for funding of SANAC due to these issues, we're scraping around, having to ask from each government department to contribute such, and even not in a structured way. So we want to make sure that this is structured, and that is why we really require support from committees such as yours. And I think this is very important for us. Thank you, Chair.
All right, thank you so much, Malaka. So, Chair, maybe from myself, in closing, I think the colleagues have touched on the issues, but I would like to speak on the issue that Honorable Femi raised on the cultural issues and how they contribute. I think when we saw the issue of Ubutwala coming back in KwaZulu-Natal, we took this issue to our local secretariat in KZN, and it's one of the issues that they did address because young girls were actually being forcefully married by being carried, and some of them were actually acquiring HIV in that. I can't say it's completely sorted, but it does help that the 18 sectors of civil society actually includes a traditional leaders sector as well as a traditional healers sector. So our ability to engage with traditional leaders to say that certain things are no longer culture, it's just a crime, it's wrong. So we were able to do that. And then on the Eastern Cape, for instance, and other provinces that have seen mortalities due to circumcision being done utilizing traditional methods. I think not to say those are not important, but what we found some of them doing, for instance, in the Eastern Cape, is that they looked for male nurses that had been graduated in those particular circumcision schools. And they are the ones that are now conducting the circumcisions, and they are supported by a medical team with, for instance, liquids in case dehydration becomes a problem. So I think all in all, we didn't have enough time, Chair, to put it forward as we would have liked to. But I think our ability to convene all the sectors has really allowed us to have the working groups that are looking at different frameworks that affect the multi-sector nature of this HIV, TB, STI pandemic that we are dealing with, especially with the emerging priorities. Back to you, Chair.
Thank you very much, CEO, as well as the team for your responses. If there is some things that you want to give us the details on, you may do so in writing. We will appreciate it. And we will want to thank you for your hard work with the minimum funds, and we will get back to you in terms of that request that you have submitted to the committee. Thank you very much, CEO, to you and the team, and we release you.
Thank you so much, Chair, and thank you to the honorable members. Bye-bye. Thank you.
Bye, CEO. Thank you.
Thank you.
Marcel, I will request you to flag the agenda.
Sorry, Chair, do you want me to flag the agenda, or do you want to go through the program?
No, the agenda, because in terms of the agenda, it's indicating the minutes is first. We must approve the minutes first. Yes, honorable members, we are now at the agenda point of consideration and adoption of the committee minutes. Marcia, can you please flag that minutes? Honorable members, the minutes of the 24th of June 2026, we have received it. Can I get any amendments, or can I get a move for the adoption of the minutes?
Honorable Sibande, I move for the adoption of the minutes.
Thank you very much, Honorable Sibande. Can I get a seconder? Honorable members, can I get a seconder for adoption of the minutes of the 24th of June? Thank you, Honorable Du Plessis.
Second the adoption of the agenda, Chair.
Thank you very much, Honorable Du Plessis. So now, Marcia, you can flag the third term program. Honorable members, we have received that one as well. Can I get a mover for the adoption of this third term program of the Select Committee on Social Services? Honorable Adriaanse.
Thank you, Honorable Chairperson. I move to for the adoption of the third term. Thank you, program. Thank you.
Thank you very much, Honorable Adriaanse. Honorable Basumpa.
I support the adoption of the program.
Thank you very much, Honorable Basumpa. So the third term program is adopted. Honorable members, in terms of we are moving now to any other business, like we have seen on the third term program, We will have a joint meeting with the Portfolio Committee on Social Development next week. And in this meeting, we will get a briefing on the annual report of the CDA. And we will also get a briefing on the process, on the recruitment process for the CDA board members. But at next week's meeting, we have to elect a subcommittee to drive this process, this recruitment process. So from our side, from our select committee side, the composition, there will be 4 MPs, and from the side of the Portfolio Committee, there will be 4 MPs. And the members from our side will be as follows. The composition will be as follows. 2 from the ANC, 1 from the DA, and 1 from the EFF. So I just want to indicate to members, you must talk to each other as parties to indicate which members will serve on the subcommittee. I will be like an ex officio as the co-chair. Any bite on this announcement, honorable members? Nothing from your side. So I assume, Marcel, we are finished with the agenda.
Yes, Chairperson, our meeting has come to a close.
Thank you very much, Marcel. So thank you very much, honorable members, for your indulgence. We really appreciate your time and effort, as well as your comments and questions to the SANAC. And thank you, and thanks to the support staff. We really appreciate you guys. So this meeting stands adjourned. Thank you very much, honorable members and officials.
Thank you, Chairperson.
Lekker dagie, voorzitter.
Thank you, honorable Pitt.